Hello, everybody, and welcome to today's course, Practical Strategies for a Safe and Effective Delivery of Aerosolized Medications to Patients with COVID-19. It's with great pleasure that I introduce today's speaker, Dr. Arzu. Dr. Ari is a physical therapist and respiratory therapist by training with 25 years of experience as a manager, clinician, educator, and researcher. She's the first Turkish physical therapist to pass the NBRC exam for respiratory therapists and pulmonary function technologists. After she graduated from the Department of Physical Therapy and Rehabilitation at Hacettepe University in Ankara, Turkey, Dr. Ari completed her master's degree in public health at Istanbul University. She received her second master's degree in respiratory therapy and Ph.D. degree in educational policy and higher education administration from Georgia State University. Currently, Dr. Ari teaches in the Department of Respiratory Care at Texas State University. Dr. Ari's interest in research has manifested in 77 abstracts, 68 peer-reviewed articles, 14 book chapters, two clinical practice guidelines, and 2 books. She's the first author of the book entitled A Guide to Aerosol Delivery Devices for Respiratory Therapists, 2nd edition, published by the American Association for Respiratory Care in 2009. This book was downloaded by approximately 3 million people around the world and has been translated into multiple languages. Since October 2000, she's been recognized as an outstanding faculty and received 21 prestigious awards for her many accomplishments in research and education. Dr. Ari's current position at Texas State University affords her the facilities and finances to continue her groundbreaking research in the field of aerosol medicine, which has a direct impact on the health of patients with pulmonary disease. Furthermore, her work is the foundation from which others are performing research with direct clinical applications. For example, her research has led to the amazing contributions and novel methods of aerosol delivery to various patient populations. With such outstanding accomplishments to date, Dr. Ari has been recognized as an outstanding researcher in the field of aerosol medicine, and her work has received the prestigious Monahan-Trudell Fellowship for Aerosol Technique Development from the American Respiratory Care Foundation 3 times in the past. She's also received the Mitchell-Barron Achievement Award for Clinical Excellence in Aerosol and Airway Clearance Therapies in 2018. Dr. Ari became a fellow of the American College of Chest Physicians and of the American Association for Respiratory Care. Dr. Ari serves on the editorial boards of the Journal of Aerosol Medicine and the CSRT's very own CJRT. She is the topic editor of Pharmaceutics. As a strong advocate for the development of respiratory care profession worldwide, Dr. Ari has served as the governor of Turkey at the International Respiratory Care Council for 25 years. She is the first elected official from Turkey by the International Respiratory Care Council and promotes the profession of respiratory care around the world. Dr. Ari has also served on numerous committees of the American College of Chest Physicians, American Respiratory Care Foundation, International Society for Aerosols and Medicine, American Association for Respiratory Care, and the Turkish Respiratory Society. So it is with absolute great pleasure that I turn things over to Dr. Ari for today's presentation.
Thank you very much for this kind introduction, Carol, and it's always a pleasure to work with colleagues at the Canadian Society for Respiratory Care, and I'm honored to present at your society today. In my presentation today, I'm going to review current evidence to provide clinicians in Canada about practical strategies for a safe and effective delivery of aerosolized medications to patients with COVID-19. I would like to disclose my relationship with the CHAST Foundation, Bayer Pharmaceuticals, ARC Medical, Synovium Pharmaceuticals, and Aerogen Limited. There are 4 objectives today that I would like to accomplish during my presentation today. First, I am going to talk about fugitive emissions to explain what they are, why they are important in this global pandemic, and how they impact viral transmission. Second, I am going to explain types of aerosols to differentiate medical aerosols from viral aerosols. It is very important to understand the difference between these 2 terms, and that's something we are going to discuss during my presentation. Then I will review the literature to provide you some practical strategies for aerosol drug delivery to mild, moderate, and severe patients with COVID-19. And at the end of my presentation, I am going to provide you some infection control and prevention practices that you can use in your hospital when you administer aerosolized medications in the era of COVID-19. As of today, more than 6.7 cases of COVID-19 have been reported worldwide, and almost 400,000 people died because of COVID-19. As you can see from this map, coronavirus is everywhere in the world. Since the virus spreads through droplets, via droplets and close contacts, fugitive emissions have been a real concern among clinicians, patients, and caregivers. Therefore, it is important to explain what they are, why they are important, and how they impact viral transmission. Some of you may not be familiar with the term fugitive emissions. Therefore, I wanted to define this term before I explain the concept. When I say fugitive emissions, I'm talking about aerosols that have been released from the aerosol device during patient expiration. In other words, they are medical aerosols that are not inhaled by the patient but passes into the atmosphere. They are medical aerosols, they are generated by aerosol delivery devices, and they are not inhaled by the patient. So we have them in the atmosphere. Why they are a big concern? Well, according to the previous studies, 50% of generated aerosols are fugitive emissions. And the particle size of fugitive emissions ranges from 0.86 micron to 1.43 micron. And as you can see, they are very small and respirable, and that's why they are, that's a big concern. Also, the virus can remain viable and infectious in aerosols for hours and on surfaces up to days. Therefore, aerosols and fomite transmission of SARS-CoV-2 is plausible. You have every right to be concerned about fugitive emissions. How does it impact the transmission? This is a study that was conducted by Wei and his colleagues a few years ago, in which they measured the maximum dispersion distance of smoke particles through the jet nebulizers in 3 different conditions, including normal lung, mild lung injury, and severe lung injury. When they used the jet nebulizer, the maximum dispersion distance of smoke particles was 0.45 meter in normal lung, as opposed to 0.54 meter in mild lung injury. It was much more in severe lung injury. It was more than 0.80 meter. And you can see the difference between those 3 pictures. So there are a couple of points that I'm going to make here about this study. First, they used the jet nebulizer. And as you know, every time when we use a jet nebulizer, we need compressed oxygen or air or compressor. We set the flow rate to 6 to 8 liters and 8 liters per minute to operate the nebulizer. And that's why we disperse aerosolized medications or the fugitive emissions to the environment. And the other thing is that they looked at smoke particles here in this study. The particle size of smoke particles is less than 1 micron, as opposed to bioaerosols that ranges from 0.1 micron to 100 micron. So the findings of this study actually represent a small portion of bioaerosols. But it is very difficult to differentiate medical aerosols from bioaerosols. So still, this is a very good study to understand how much smoke particles distribute or disperse when we use the jet nebulizer. I said bioaerosols, I talked about medical aerosols, and you may say, what are they? What's the difference between them? And that's why I wanted to explain the types of aerosols in this slide. Bioaerosols are generated by patients during cough, sneeze, laugh, or talk. Even singing can generate bioaerosols. Medical aerosols, on the other hand, are generated by an aerosol delivery device, such as inhalers or nebulizers. So the source of bioaerosols here is the patient, as opposed to medical aerosols in which the source is the aerosol delivery device. If your patient is infected, of course, bioaerosols will carry pathogens. What about medical aerosols? Do medical aerosols carry pathogens? The answer to that question is yes, if the device is contaminated. And you may say, how am I going to contaminate the device? Well, it's very easy, actually. If your patient's secretion drops in the reservoir of the nebulizer that you use during treatment, it will be contaminated, and medical aerosols will carry pathogens. Sometimes we as healthcare professionals are responsible for device preparation, and we are not careful enough during the preparation of the device and contaminate the device, especially if we use it repeatedly on the same patient. Also, device features makes a huge influence on the risk of contamination of the device. And that's something I'm going to talk about in a few minutes, so I'm not going to explain it here at this slide. And then the next question is, can medical aerosols become contaminated in the lung before exhalation? Let's say the device is not contaminated. In this case, medical aerosols that we inhale but not deposited in the lung, but at the end we exhale those particles. Are they contaminated? What about exhalation of inhaled aerosols? Are they contaminated? Well, this is a big question mark. We do not know the answer to that question. Right now, there is no study showing that's the case. There are many different types of aerosol delivery devices on the market. And I would like to review each category in terms of aerosol drug delivery and transmission of bioaerosols. I'm going to start with the PMDIs. As you all know, PMDIs have low emitted dose and generate less aerosol mass than nebulizers. Drug preparation is not an issue with the PMDIs because drug is enclosed in the canister and it is hard to contaminate the PMDI during device preparation. Therefore, the risk of virus transmission is very low with the PMDI. If you need to use the PMDI in your patients with COVID-19, I recommend for you to use it with a wide holding chamber that has a mouthpiece. There are several reasons for that. One is that you can reduce oropharyngeal deposition when you use the PMDI with a wide holding chamber. Secondly, you can actually improve the delivery efficiency of the device, that you can deliver more aerosols to the lungs of your patients. But most importantly, especially in this era of COVID-19, you can ask your patient to exhale inside the wide holding chamber. That way, if the exhaled bioaerosols carry pathogens, it will stay inside the wide holding chamber instead of going to the atmosphere. So that's very important. That's why I recommend for you to use the PMDI with a wide holding chamber in patients with COVID-19. What about the DPI? It is very similar to the PMDIs because drug is enclosed here in this device, especially if you're using multi-dose DPIs like in this picture. Since drug is enclosed in the device, it is less open to contamination. And when you prepare the device for aerosol therapy, it's very hard to contaminate the device. However, we know that the DPI is highly dependent on the patient's inspiratory flow rate. In order to use the device effectively, patient needs to generate high inspiratory flow rate during inspiration. So we ask them to take a fast and deep breath. When they do that, they may start coughing or they may have airway irritation. If that's the case, virus transmission would be medium. And in that type of situations, we do not want to use the DPI in patients with COVID-19. I also don't recommend for you to use the DPI in acute respiratory failure because those patients will not be able to generate high inspiratory flow rate that are needed to use the flow rate that is needed to use the DPI correctly. They will not be able to take fast and deep breath through the device. So it's not going to be a good device to use in that type of situation. One other thing that I would like to emphasize is the humidity. We all know that humidity impacts the function of DPI. So we don't want our patients exhale inside the device. So you need to instruct your patient not to exhale inside the device when they use the DPI. Also, we should not keep the device in high humidity environments such as bathrooms. What about the jet nebulizer? That is the most problematic aerosol device in this pandemic, in my opinion. Because they are open to contamination. We always use flow rates to operate the device, and flow rates used with the jet nebulizer actually increase aerosol dispersion in spontaneously breathing patients. If you want to use it in ventilator-dependent patients, you need to break the circuit to place the device on the ventilator circuit and deliver the medications. And every time when you want to use the jet nebulizer, you break the circuit, you put the medication in, and that you attach it to the circuit again. But when you break it, you actually expose yourself to the bioaerosols inside the circuit, and that's a problem in this pandemic. We don't want to break the circuit during mechanical ventilation, especially if your patient has COVID-19. It is easy to contaminate the jet nebulizer during device preparation, especially with repeated use. Therefore, the risk of virus transmission is high with jet nebulizer if patient secretion drops in the reservoir. And it's very easy actually, because think about it, if your patient breathes through the mouthpiece, it's very easy to drop the secretion inside the reservoir here because it has an open design. So I wouldn't recommend using the jet nebulizer for aerosol drug delivery in the era of COVID-19. However, if you have to use it, I would say pay attention to device preparation, cleaning, and maintenance. Also, use it with the mouthpiece like in this picture and attach a filter here at the exhalation port. What about the mesh nebulizer? It's a little different than the jet nebulizer because the mesh that is located here actually separates the drug here in the reservoir from the patient interface. So it is hard to contaminate the medication and when you use it during mechanical ventilation, you don't need to break the circuit to place the nebulizer. So that's another advantage. Therefore, it is hard to contaminate the device and the risk of contamination is low with the mesh nebulizer because patient interface is separated from the medication. If you use the mesh nebulizer in your patients with COVID-19, it doesn't matter if your patient is spontaneously breathing or receiving mechanical ventilation. I would suggest for you to keep the reservoir cap closed after use. That's important. This is a study in which they looked at the risk of SARS transmission to healthcare professionals with various aerosol generating procedures, including tracheal intubation, suctioning, non-invasive ventilation, and nebulizer treatment. Actually, they looked at many more aerosol generating procedures, but I just chose those 4. So this is a retrospective study in which they did a pooled analysis. And they found that if healthcare professionals do tracheal suctioning, they increase their risk of SARS transmission by 6.6-fold. It was 3.5 with suctioning and 3.1 with non-invasive ventilation. Look at the number with nebulizer treatment. It is 0.9. Everybody is thinking that nebulizers are aerosol generating procedures. Yes, that's correct. But compared to the other procedures that we perform on our patients, it is not as risky as others, at least based on the findings of this study. Now let's talk about aerosol delivery to mild patients with COVID-19. Of course, device selection is very important in this patient population. Let's say your patient is awake and can perform the optimum delivery technique required by the inhalers. In this case, use the PMDI and attach the PMDI to a wide holding chamber. The wide holding chamber should have a mouthpiece. If your patient cannot use the PMDI or if the drug is not available as a PMDI, in this case, DPI could be your option if your patient can generate high inspiratory flow rate during inspiration. If your patient starts coughing or has an airway irritation during treatment, do not use the DPI because you will expose yourself with bioaerosols that will be a risk for you. Sometimes the drug formulation is not available as an inhaler. So what are we going to do in this case? Actually, in these days, we have a shortage of inhalers in the United States. So what are we going to do? Well, in that type of situation, we have to use a nebulizer, but we should prefer using a mesh nebulizer over a jet nebulizer. And every time when we use a nebulizer, we should attach a mouthpiece to the nebulizer. We should not use a face mask. And we should use the nebulizers with a filter. So let's talk about the filters now. Attaching a filter to the nebulizer or the exhalation port of the nebulizer, like in these pictures, is very important. Because when you attach a filter here, you reduce the dispersion of exhaled aerosols. There are a couple of things that I would like to mention here. If you have a HEPA filter in your unit, use a HEPA filter for your nebulizers. These are bacterial filters, which will be okay, but HEPA filters will be best in terms of capturing bioaerosols than bacterial filters that you see in those pictures. One problem with the attachment of HEPA filter is that they are big and bulky, and sometimes it may be a challenge to find the right adapter to attach those filters to the nebulizers. When you attach a bacterial filter to your nebulizer, you can actually capture 93% of exhaled aerosol droplets. That's a huge reduction, and that's very nice actually. We want to have, we would like to make sure that we are safe when we provide those treatments. There are a couple of things that I would like to mention here. This particular study actually is a laboratory study in which they captured medical aerosols, not bioaerosols. So we do not know if that number is true for bioaerosols. It is probably, but that's not easy to say without seeing the data. As I said, bioaerosols are different than medical aerosols, and it is very difficult, almost impossible, to differentiate bioaerosols from medical aerosols. It is difficult to say this is bioaerosol, this is medical aerosol in a laboratory study like that. This is a nice study conducted by McGrath and his colleagues. In this study, they quantified exhaled aerosols released into the environment with the jet and mesh nebulizers. So they combined those nebulizers with the mouthpiece and the face mask and basically measured aerosol concentration in the air. So here are the data they got. First, they looked at two different nebulizers, jet and mesh nebulizers that are attached to the face mask, unfiltered mouthpiece, and filtered mouthpiece. So when you look at these numbers, face mask is the worst. And you can see that actually here. This is the data that they obtained with the jet nebulizer attached to a face mask. And that makes sense, right? Because when you use a face mask, it has an open system and you disperse all the aerosolized medications to the atmosphere. The mouthpiece, unfiltered mouthpiece is better compared to the face mask, but filtered mouthpiece is the best. And of course, vibrating mesh nebulizer is much better than the jet nebulizer because you do not need to use extra flow to operate the device, unlike the jet nebulizer. So if you have the vibrating mesh nebulizer in your unit, attach a mouthpiece, put a filter to the mouthpiece, and then use it to deliver the medication to your patient. When you use a mouthpiece with nebulizers, you also increase the efficiency of the device. This is a study that we conducted in our research lab several years ago. In this study, we looked at the delivery efficiency of the jet and mesh nebulizers using the mouthpiece and aerosol mask. The findings of our research showed us that drug delivery was greatest with the mouthpiece, and the aerosol mask was the least efficient device. And of course, we confirmed that the delivery efficiency of jet nebulizers was less than mesh nebulizers, and right now there are many more studies showing the same thing in the literature. So using the mouthpiece increases not only delivery efficiency of the device, but it is also safer in terms of aerosol drug delivery and exhaled dispersion of exhaled air. So here are some practical strategies for aerosol drug delivery to mild patients with COVID-19. My first suggestion to you is that to avoid unnecessary aerosol drug delivery to your patient. If your patient doesn't need any aerosol treatment, don't do it. If you have to give a medication, aerosolized medication to your patient, use inhalers for aerosol delivery instead of nebulizers. In this case, your first choice should be a PMDI. If that's not an option, the DPI will be your second best choice if your patient can generate the high inspiratory flow rate and perform the optimum delivery technique. But sometimes we do not have the drug formulation as inhaler. In this case, we have to use the nebulizers. And in that type of situations, we should attach filters to the nebulizer and also use it with a mouthpiece. We also should administer aerosol therapy in negative pressure rooms and wear personal protective equipment, including N95 respirators, goggles, face shield, double gloves, gown, and apron. What about aerosol delivery to moderate patients with COVID-19? Let's talk about that. Those type of patients usually have hypoxemic respiratory failure and may need to use the high-flow nasal cannula. However, right now there is a big debate about the use of high-flow nasal cannula on patients with COVID-19. There is one group who supports the idea as opposed to the other group who is totally against of using the high-flow nasal cannula in this patient population. The group who supports the idea says that we should use the high-flow nasal cannula because it is very well documented that it is effective in the treatment of hypoxemic respiratory failure. They say we have limited number of ventilators, and remember, intubation is a high-risk procedure. Also, we do not want to, prolong their stay in the ICU because we have limited number of ventilators and we have limited number of resources available in the ICU. So they say because of all those reasons, we should use the high-flow nasal cannula. The other group is totally against it, and they say, no, we should not use it because the dispersion of bioaerosols with the high-flow nasal cannula is very high, and increased dispersion may lead to viral transmission. It is too risky. We should avoid using the high flow nasal cannula in patients with COVID-19. So let's talk about the dispersion of exhaled air with the high flow nasal cannula now. In this particular slide, I am going to present you two different studies that use the same methodology and similar breathing parameters. The study that you see here, over here, was conducted by Wei and his colleagues using the high flow nasal cannula at 6 liters per minute and 10 liters per minute. They measured the smoke particles or the dispersion of smoke particles with the high flow nasal cannula. In here, I copied a table that I got from the study conducted by Ipe and his colleagues, in which they also measured dispersion of smoke particles using different oxygen delivery devices, including the simple mask, non-rebreather mask, and Venturi mask. So when this study measured the smoke particles with the high flow nasal cannula at 6 liters per minute, the maximum dispersion distance of smoke particles was 17.2 centimeters. And that number was actually very close to the simple oxygen mask that was set at 15 liters per minute. Look at the number here. It is 11.2 centimeter. And if you review those numbers that they got with the non-rebreathing mask and Venturi mask, they have much higher dispersion distance than the high flow nasal cannula at 60 liters per minute. And Wei and his colleagues actually reduced the high flow nasal cannula, the flow rate in the high flow nasal cannula, from 60 liters per minute to 10 liters per minute. And look at the number here, it is 6.5 centimeter. It is much less than 10 liters per minute with the simple oxygen mask. So we think that the dispersion distance of bioaerosols is an issue with the high flow nasal cannula, but according to those studies, it's not as problematic as a simple oxygen mask. So maybe we can use the high flow nasal cannula in this patient population. Well, you may say maybe dispersion is not a problem. What about bacterial contamination or bacterial growth? And this is what I'm going to present you in the next slide. In this particular study, they actually did a clinical trial of 19 patients using the high flow nasal cannula at 60 liters per minute, an oxygen mask at 8.6 liters per minute. They measured bacterial growth through patients' room air and settle plates that were placed 0.4 meter and 1.6 meter away from the patient. And according to this study, there is no significant difference in bacterial growth in the air sample and settling plates between the high flow nasal cannula and oxygen mask at 1, 2, and 5 days of incubation. So, because of all those evidence and also the publication that was released by the Chinese Medical Association, we recommend using the high flow nasal cannula in moderate patients with COVID-19. There are a couple of things that you need to pay attention when you use the high flow nasal cannula in this patient population. First is that you need to place the vibrating mesh nebulizer prior to the humidifier to improve the delivery efficiency of your device. And then, secondly, you need to make sure that the prongs are well fitted here in the nares and they are not loose. Also, when you use the mesh nebulizer here, make sure the reservoir cap is always closed after each use. And then one other thing that I'm going to suggest for your clinical practice on aerosol delivery to moderate patients with COVID-19 is to use a mask on your patient during treatment. Why do you need to use a mask? Well, this is a study in which they compared the impact of mask on exhaled air dispersion. They looked at no mask, surgical mask, and N95 mask. They compared their data in these three conditions. And you can see how much aerosols can be dispersed when your patient doesn't have any mask on their face. In surgical mask, it is less. In N95, it's the best. So N95 mask was more effective than surgical mask in preventing expelled air leakage during coughing, but there was still sideway leakage. There are different types of masks available on the market. One thing that I would like to mention is that some of the N95 respirators have an exhalation valve that is located in the center of the mask, like in this picture. If you have this mask in your unit, do not use it on your patient because the exhalation valve on this mask will open during exhalation, and our goal is to reduce exhaled air dispersion. So with this type of valve, actually you will increase exhaled air dispersion. That's why you should not use it. If you have an N95 respirator without valve, you can use this one on your patient. But if you say, well, our resources are limited, we should use N95s for healthcare professionals. In this case, I would say use a surgical mask. That would be also a good one to use. There are a couple of things that I would like to emphasize for aerosol drug delivery through high-flow nasal cannula. Because my goal in this presentation is to provide you some practical strategies for a safe and effective treatment. So sometimes when I give lectures on high-flow nasal cannula, they say, well, we do not know how to set up the system. We don't know how to deliver aerosolized medications to patients using the high-flow nasal cannula. So here is a picture that will show you how you should set it up. So as I mentioned to you earlier, you need to place the vibrating mesh nebulizer here prior to the humidifier. You see this safety valve comes on top of it, and then you attach the flow meter right here, and this is the controller that you are going to use to operate the device. So it's very easy. It's an easy setup. You shouldn't have any problem with it. This is a study that we conducted a few years ago with my colleagues in Brazil. In this study, actually, we looked at radio-labeled aerosol deposition. This is a scintigraphy study, and we took those beautiful pictures of radio-labeled aerosol deposition in the lung. So we tested aerosol drug delivery with the high-flow nasal cannula at 10 liters per minute, 30 liters per minute, and 50 liters per minute. As you can see, 10 liters per minute was much better in terms of lung deposition. When we increased the flow rate from 10 to 30 liters per minute, lung deposition decreased significantly to 5.7%, and it was much less with 50 liters per minute. So if you would like to provide a efficient therapy to your patient, you can actually use a lower flow during treatment. Let's say your patient can tolerate 10 liters per minute for a short period of time. In this case, you can decrease the flow rate to 10 liters per minute and deliver aerosolized medications at that flow rate. And then you can go back to your original setting. And remember, when you use a mesh nebulizer, it actually takes only a few minutes to deliver the drug. So it shouldn't be a problem in terms of your patient's tolerance. But if it is a problem, don't use that technique. This is a technique that I'm suggesting for patients who can tolerate lower flow rates. So here are some practical strategies for you. Use the high-flow nasal cannula for aerosol delivery before your patient develops severe hypoxemic respiratory failure. I am one of those clinicians who thinks that we should use it in our clinical practice. Use the mesh nebulizer with the high flow nasal cannula. Place it prior to the humidifier and keep the reservoir cap closed. Always place a mask on your patient's face before therapy, excuse me, to reduce exhaled air dispersion to the environment. Administer aerosol therapy in negative pressure rooms and wear personal protective equipment. You are important to us, and I would like to make sure you're safe. So always wear a personal protective equipment. So let's talk about aerosol delivery to severe patients with COVID-19. According to previous research, 2/3 of patients with COVID-19 develop ARDS. Therefore, we usually put them on mechanical ventilator. They are ventilator-dependent patients. So what are we going to do in this type of situation? In ventilator-dependent patients with COVID-19, our goal should be to keep the circuit intact to prevent virus transmission. So we should not use a jet nebulizer or PMDIs for aerosol delivery due to breakage of the circuit for device placement. So what are we going to use? I recommend using the mesh nebulizer in this type of situation because they can stay in line up to 28 days. The reservoir design here actually eliminates the breakage of the circuit. You place the nebulizer prior to the humidifier and you can keep it there for 28 days without breaking the circuit. And you should also keep the reservoir cap closed here after each use. This is a recommendation that was made by the Chinese Medical Association's guideline that was published last February. And they actually cited 2 of our papers in their guideline. And one of them is this one, in which we evaluated the efficiency of the jet and mesh nebulizers in 2 different nebulizer positions. One of them was at the Y, the other one was prior to the humidifier. We also looked at the effect of bias flow on the delivery efficiency of those devices. As you can see from this figure, when we placed the nebulizer prior to the humidifier, we increased aerosol drug delivery to our patients. Inhaled dose was significantly higher than when we placed it at the Y. When we increased the bias flow from 2 liters per minute to 5 liters per minute, aerosol drug delivery decreased. So I would recommend using the nebulizer prior to the humidifier based on the findings of this study. And after our study was published, there were a couple other studies that evaluated similar parameters and they confirmed the findings of our research. Another study that was published in the guideline of the Chinese Medical Association was this one. In this research, we looked at the effect of expiratory filters on secondhand aerosol exposure. A few years ago, one of my good friends and colleague, Ms. Sue Pilbim, called me and said, Arzu, how much aerosols do we inhale in the ICU? How much aerosols were released through the mechanical ventilation? I said there is no study on that, and it is easy for us to measure that in our research lab. So we collaborated on that particular study and looked at the effect of expiratory filters on secondhand aerosol exposure. So we developed a lung model, excuse me. We developed a lung model, experimental lung model, in which we didn't have any expiratory filters. And at that time, that was the standard of practice in many hospitals. They didn't think they need an expiratory filter on the expiratory outlet of the ventilator. And then measured all the aerosols coming through the ventilator at the end of each treatment. And then we repeated the same testing with the same ventilator, with the same conditions using an expiratory filter on the expiratory outlet. And we again collected all the aerosols during treatment at the exhaust filter placed right here. We tested several different ventilators that were available in our research laboratory at that time. And the results of this study was quite shocking, actually. We found that drug deposited at the exhaust port without expiratory filtering was more than 160-fold higher. It was higher than with expiratory filtering. So when you don't place an expiratory filter like in this picture, you deliver 160-fold more aerosols to the environment. So I would suggest place an expiratory filter here to the expiratory outlet of the ventilator. And another finding of this study is that HEPA filters was much more efficient than regular bacterial filters. So attach a HEPA filter to the environment, to the expiratory limb of the ventilator. In terms of practical strategies for aerosol delivery to severe patients with COVID-19, I would say use the mesh nebulizer and place it prior to the humidifier. Attach a HEPA filter to the expiratory limb of the ventilator. Do not combine aerosol therapy with pulmonary clearance. Use inline catheters for suctioning patients during mechanical ventilation if you need to suction your patient. Always wear personal protective equipment. Let's talk about infection control now. Aerosols entering the ambient environment increase the risk of exposure to the virus. So we may expose to the pathogens during patient treatment, monitoring, equipment cleaning, or maintenance. Therefore, I think we should assume all patients are infected. I think that's what we should assume, and therefore we should apply good personal protection and good aerosol therapy practices. So how we are going to do that? Let's talk about that. First, we need to isolate patients in negative pressure rooms with 12 air changes per hour. 160 liters per second per patient. We need to bundle activities and minimize the number of times entering the room. We should train our staff on infection control and prevention in the era of COVID-19. And of course, we need to wear personal protective equipment to protect ourselves from bioaerosols carrying pathogens and adhere airborne precautions. As always, we need to wash our hands before and after each treatment. At the beginning of my presentation, I said I have 4 goals that I'd like to accomplish today during my presentation today. I said I'm going to talk about fugitive emissions. I will say what medical aerosols and bioaerosols are. As I mentioned to you earlier, they are different. Medical aerosols are generated by an aerosol delivery device such as an inhaler or nebulizer, as opposed to bioaerosols that are generated by patients or people who sing, talk, cough, eat, whatever they do. I said I will talk about infection control and provide you some practical strategies for mild, moderate, and severe patients with COVID-19 and explain how to deliver aerosolized medications to this patient population. So every time when I give a lecture, I always emphasize the highlight of my talk so that you would remember what I said. So here's the repetition of my previous slide. Let's say you are going to treat a mild patient with COVID-19. In this case, you should avoid all unnecessary aerosol drug delivery to this patient. If your patient has to have an aerosol treatment, your choice should be inhalers instead of nebulizers. Attach filters to nebulizers before aerosol therapy, and that's something you should do if inhalers is not an option. Sometimes patients cannot perform the optimum delivery technique with inhalers. Sometimes we do not have inhalers available. In other times, drug formulation is not available as an inhaler. So in that type of situation, we can use a nebulizer, but we should attach the nebulizer to a mouthpiece and use it with a filter. Administer aerosol therapy in negative pressure rooms and wear personal protective equipment. As for aerosol drug delivery to moderate patients with COVID-19, as I mentioned to you earlier, we can use the high flow nasal cannula for aerosol delivery before they develop severe hypoxemic respiratory failure. In this case, we should use the mesh nebulizer, place it prior to the humidifier, and keep the reservoir cap closed after use. I said you need to make sure that the prongs are in place. It is they are well fitted and they are not loose. And you should place a surgical mask on the patient's face before aerosol therapy. Also, if you use the mesh nebulizer with the high flow nasal cannula, since the treatment takes only a few minutes, you can decrease the flow rate to 10 liters per minute to deliver the aerosolized medication in the most efficient way. And after that, you can increase the flow rate to the level that your patient needs. But that's something you should do if your patient can tolerate lower flow rate. As always, administer aerosol therapy in negative pressure rooms and wear personal protective equipment. In conclusion, I would like to quote one of my favorite saying from Marie Curie. She said, "Nothing in life is to be feared, it is only to be understood. Now it is time to understand more so that we may fear less." There are so many unknowns and so many question marks we have about coronavirus. We are worried about the resources, lack of resources and knowledge we have. But please remember, we are strong when we know our fears and limitations. It is time to think about what is necessary and doing what is possible. We have the knowledge and experience about how to deliver aerosolized medication to this patient population, and you can use a proactive and comprehensive approach when delivering aerosolized medications to your patient in your clinic. If you haven't read my article yet, I recommend for you to read it if you're interested in learning more about it. It is published in Respiratory Medicine last April, and it is free of charge as far as I know. If not, email me, I'll send you a copy of that article. So once again, I would like to thank you for being here with me today, and my sincere appreciation goes to the Canadian Society for Respiratory Therapy. It's always a pleasure to be with colleagues from Canada. If you have any questions, please feel free to email me. Thank you.